In this episode of Being Well, I sit down with HSHS Medical Group's Dr. Bernie Ranchero to talk about an emerging and effective tool in a doctor's tool belt for weight loss, using what's been traditionally thought of as medicine to treat diabetes as a way to help patients lose weight.
When Sarah Bush Lincoln opened in 1977, it was with the promise to serve the community's healthcare needs. It has grown into a 2-hospital system with nearly 60 clinics that provide trusted, compassionate care.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
Thank you for joining us for this episode of Being Well. I'm your host, Lacey Spence, and today we're welcoming back an old friend of the show. We've got Dr. Bernie Ranchero, now with HSHS Medical Group. Glad to have you back for another season.
Thank you. Great to be back here with you.
Back-to-back seasons,
Yes.
And we've got a fantastic topic. Things are kind of developing and evolving, so just to let our viewers in, we are recording this in June of 2023, but the latest and greatest is kind of coming out all the time.
Correct.
So we're talking about diabetes medicine for weight loss.
Yes.
Is there a good place to start? How did this kind of come about?
Well, it's interesting. I think diabetes, obviously, we've been treating diabetes for decades.
Yeah.
But now we realize that we always have known obesity and excess weight, excess adipose tissue is a risk factor for many conditions, and especially diabetes. And so we've realized in the last 10, 15 years, a lot of the medications we use for diabetes work really well to help patients treat their obesity. And when I mean, and I think I've had this topic before, obesity is a disease just like asthma, just like diabetes, just like depression. It's a chronic disease and it's treatable. And I think now that we have some amazing medicines, we're realizing that we can treat it in very effective, long-term ways.
So before we really dive in, just to back up,
Yes.
what are some other pre-treatment measures before maybe diving into
Sure.
this type of medicine?
So just like any chronic disease, you should always start with lifestyle modifications.
Okay.
So whether it be high blood pressure, high cholesterol, high blood sugars, what are the lifestyle modifications we can do? So if we're treating excess weight, obviously, one of the things is, can we decrease our sedentary lifestyle and increase our physical activity? Can we make healthier food choices? Can we lessen our stress? That's a big one. Sleep better. That's a huge one too. And then maybe also, are there supplements and herbs and other things that we can do to help our bodies build up a good immune system and help our bodies to be more natural in finding and controlling our wellness and our weight?
Yeah, and so let's say we're already kind of working on all of that, but we want to know if we are maybe a good candidate for trying this medicinal route. So what would make someone a good candidate?
Well, what makes someone a good candidate, number one, you just like anything, say if you were a smoker, you have to first acknowledge that, hey, I have a problem, I need help for this problem.
Yeah.
So some of it is, okay, just like smoking, if you don't recognize that you need help or that you can't do it on your own, and that's the first thing. And then also, there are many things out there that people have tried, whether it be commercial products like Weight Watchers, or over-the-counter supplements, or over-the-counter medications that are available, such as Ally, which helps prevent us from absorbing fat. Things are available that are not necessarily prescription. But then if our weight and if you will, BMI, body mass index. It's not a perfect way to screen for excess weight and obesity, but it's a screening tool we use. So we say if you have a BMI of 27, which puts you in the overweight category, and you have another condition that is unfortunately made worse by obesity, then we say you qualify for a medication. Or if you have a BMI of 30, which puts you in the obese category, then you qualify for these medications.
Without another condition.
Without another condition, yeah. Those other conditions can be, something like high cholesterol, arthritis, depression.
High blood pressure.
High blood pressure, absolutely. All those things that are other chronic conditions. We know that there's over 240 conditions where obesity is a risk factor. In fact, we say 40% of cancers these days have obesity and excess weight as a risk factor. And soon, probably obesity will surpass smoking and nicotine as the #1 risk factor for cancers.
Oh my goodness. And I don't know if you can speak to it, but
yes.
Why is this such a growing problem for our country and our world?
Well, if we look at it is an epidemic, and it's not just our country. It's many other countries. In fact, if you look at where obesity is growing the most, it's actually in the Middle East and parts of China and India, because of our diet, because of our lifestyle, because of stress in our life and other things. And I think part of it is that just like people sometimes use food, we have to eat. We don't have to drink alcohol, we don't have to smoke, we don't have to use nicotine, but we have to eat. And then when we eat in a way that sort of stimulates those obesity genes, or is it stress or lack of sleep or medications or stressful relationships, all those things can stimulate or induce obesity genes, and there we go. We have the disease of obesity. And we're seeing it at younger and younger ages. Unfortunately, and it's because of our diet and our lifestyle, but it's also realizing those things, those environmental factors are stimulating or inducing those obesity genes.
Mm-hmm. Well, let's dive into kind of talking about these classes of drugs, because there's certain different ones that do different things, work different ways, and I know people are really curious about kind of the new science behind it.
Yeah. So this is what, when it comes to obesity and when it comes to, we really didn't have good medicines maybe until the past 5-10 years. And some of the medicines we had in the past are stimulants, things that suppress our appetite. One of them is called phentermine. Phentermine is a stimulant that's in the same class as Adderall or Ritalin, and it just goes to the brain and says, hey, you're less hungry. And those are good medicines, but unfortunately, a lot of times it was only written for 3 months. Oh. But we know carrying excess weight and obesity is not, hey, I lose the weight and then you're cured. No, it's a chronic progressive disease that often gets worse with age, and it's very complex. So treating something for 3 months isn't the solution. I always tell my patients, losing weight is hard, but what's even harder is keeping the weight off. So it's finding a medicine that will work. And when it comes to treating excess weight and obesity, I believe it's one of the most complex diseases out there, and it has to be specifically tailored for that patient. So there's certain meds that work as an antidepressant, certain meds that are anti-addiction, certain meds that help shut off the parts in the brain that say, hey, you're hungry. And there's also certain meds that say that combat the hormones that cause us to feel hungry and lower your metabolism.
And I feel like a lot of what I'm hearing is folks are kind of diving into taking these medicines. They're talking about how huge it is to not have the food noise.
The hunger, yes.
Yeah.
And a lot of times we know the same parts of the brain that light up in someone who's an addict to substances, illicit substances, are sometimes the same parts of the brain that light up in someone who's a food addict, or someone who's, if you will, misusing or abusing food and using it in a way, oh, I'm bored, I'm gonna eat. Oh, I'm frustrated, I'm gonna eat. Oh, I'm stressed out, I'm gonna eat. Oh, I'm happy, I'm gonna eat. Oh, it's time to celebrate, I'm gonna eat.
Yeah.
And so we realize that, you know what, there's a lot of physiology and genetics that go into managing someone's weight. And we have to realize that it's not just, oh, I need to push that plate away and exercise more. No, if that was true, then everyone would be doing Biggest Loser, and we wouldn't have an obesity problem. But we know it's physiological, and it's a chronic disease, and we unfortunately don't know how to shut off those obesity genes. Not yet, at least.
Yeah. Well, and I like that you said, we have to eat.
Yes.
Because a lot of people who are food addicted or have, poor relationships with food, it's not like a smoker where you can quit cold turkey, or,
No.
you wouldn't casually drink as someone who's formerly an alcoholic. And so obesity, it's like you can't just stop eating.
Correct.
So people who are starting to take these drugs, how are they taken, or is it?
Sure.
A
So
pill,
there's numerous ways. The newest medications that we're using are something called GLP-1s, glucagon-like peptide receptor agonists. So these medications were developed for diabetes. So this is when I talk to patients, this is what happens. We eat, food goes down into our stomach, and when food goes down into our stomach, this hormone called GLP-1 is released. It's in a class called incretins. Numerous hormones are released, but this GLP-1 is released. Now, if you're a diabetic, it would have numerous activities in parts of your body. But one of the things this hormone does, it makes you feel full. It says, hey, there's food in here, digest the food, slow down the digestion. But then more importantly, this hormone goes into our blood, goes to our brain, and goes to our hypothalamus and says, hey, brain, hey, hypothalamus, there's food in here. Stop the cravings, stop the hunger, and you're full. So we know that certain peptides and certain proteins are produced when we eat that say, hey, you're full. How does someone get to be 500, 600 pounds? It's because they never feel full, or they're eating to feel normal. And so we know if we can correct some of these hormones in the brain, that guess what? That patient then feels full. That patient doesn't have the cravings. And another thing that these medicines do, these GLP-1 receptor antagonists, is they counterbalance another hormone. So a hormone that is produced when we're hungry or in a starvation state is called ghrelin. Ghrelin is the hormone that makes your stomach growl when you're, that's why they say before you go to shopping and go to a restaurant, eat something so that you don't buy everything in sight.
Yeah.
But that's produced by a hormone called ghrelin. So we remember a TV show Biggest Loser.
Yeah.
Those contestants quit their jobs, left their families for 6 months, and on average, they lost 100 to 150 pounds. And they followed these contestants. These contestants worked out for 6, 7, 8 hours a day on a strict diet. So they lost a lot of weight. But they followed these contestants, and after 6 years, what they found is 90% of those contestants gained all of their weight back plus some. And they said, why? And they looked at it, and so they measured their basal metabolic rate. The energy you expend just being you, just eating and drinking and sleeping and breathing. And what they found is when they did their basal metabolic rate before the show, and then every year for 6 years, is that unfortunately the body adapts to that weight loss and your metabolism drops. So that's why sometimes you could have someone who's, say, 200 pounds, and then say someone who was 300 pounds is now 200 pounds. Who has to work harder? The person who lost 100 pounds is now 200. Who has to eat less and who has to exercise more and have more physical activity? The person that was originally 300 pounds, because the body defended against that weight loss. One of the hormones that is overproduced is called ghrelin. And that ghrelin makes you feel hungry, makes you crave, but that hormone also lowers your metabolism.
Wow.
That's why some people, they cut their calories and they eat less and they gain weight. Why? It's not their fault. It's one of the reasons is this hormone called ghrelin. So we know now those medicines that go to the hypothalamus, the medicines that counteract those other hormones that cause you to be hungry, lowering metabolism, if we can counteract that and balance that out, then guess what? We can get in a better place where our metabolism's where it should be, where our hunger and our satiety, feeling full, is where it should be as well. And then patients naturally lose weight. And what's exciting about these medications is that these are naturally produced hormones that your body naturally produces. We're just giving them in supraphysiological doses or higher doses because your body is resistant to it.
Versus like a bunch of chemicals.
Correct. Or taking something else that might, like that stimulant I was talking about, phentermine. Well, that's what we call an exogenous compound, a medication that your body does not naturally produce.
Yeah.
So these new medicines are giving you a boost in a hormone that you already produce. So it's quite interesting. The majority of the time it's an injection, but they have come out with pill form, and that's what's another exciting thing, is that it can be more convenient for patients to simply take a pill versus doing a daily injection or a weekly injection.
With the injection, would that be something that the patient administers himself?
That's a great question. It is. We teach the patients to do it themselves.
Okay.
And it's a tiny needle. Patients rarely feel it. Of course, there's side effects to those medications. Some of the brand names of those medications that are out there, Victoza, Saxenda, some of these are diabetes and some for weight loss. And then those are weekly injections. And then there's a daily pill you can take called Rybelsus. It is just coming out that you can lose 15% of your weight on that daily pill. Right now, it's only indicated for diabetes, but maybe by the time this show airs, it will be indicated for weight loss as well for people who don't have diabetes. And then the weekly injections, that's like Trulicity, that's for diabetes. Then you have Mounjaro, that's for diabetes, that's the newest one. Then you have Wegovy and Ozempic, and those are weekly injections. And the Wegovy and the Saxenda are specifically injections indicated all the way down to 12 years old for people who suffer from excess weight. Again, a BMI of 27 with a condition that qualifies, or a BMI of 30 or more.
And so you've definitely covered the GLP-1.
Yes.
Is there any other classes of this type of drug that do different things?
Other medications, other oral medications that one can use are, like I said before, are antidepressants, sometimes mixed with anti-addiction medications. And then you have stimulants mixed with headache medications. One brand name is called Qsymia, and you could lose 15% of your weight with that. And those medicines are about $100 a month, whether it be the Qsymia or Contrave, which is a combination of bupropion plus naltrexone, so that's an antidepressant with an anti-addiction medication. Those are about $100 a month. And then Plenity is another medication you take by mouth. That's about $100 a month. You take that, and then it expands in your stomach to become a gel, so you feel full. Okay? So now, the one things I tell patients about these medications is that because obesity, carrying excess weight, is a chronic condition, you probably will have to take these medicines long term. So after you hit your goal weight on these medications, you probably will need to take these medications for at least 18 months to 2 years after you hit your goal weight, maybe even longer, because we know sometimes, unfortunately, that set point, that weight set point, even after 2 years, say that patient was 300 pounds, the body will fight itself to get back up to that 300 pounds plus some, because your fat cells have a memory, an adipose memory that, hey, we remember when we were big and full of triglycerides and full of calories, and all of a sudden we start shrinking because we lose weight, and the body thinks, oh, I must be sick.
Right, it's like it doesn't know you just want to fit into a swimsuit for summer.
And that you don't need to carry that extra weight and that extra mass. So that's why sometimes we have to think of obesity as a chronic disease.
And I think it's interesting too that you are kind of bringing up price point.
Yes.
So insurance, that can kind of be a barrier for some people, correct?
It's a big barrier. So those GLP-1s, the oral GLP-1 at this time maybe is $600 a month.
With insurance?
No, without insurance. Without insurance.
I mean, still,
yeah,
sticker shock.
But that Rybelsus I'm talking about now, until it gets FDA approved for weight loss, it's only available for type 2 diabetics.
Gotcha.
Yeah, and those GLP-1s we talked about, those once-week injections, which are extremely efficacious in helping patients lose 25% of their weight. Right now, most of them are only indicated for if you're a type 2 diabetic. It is frustrating. It's another show you can have on why do insurance companies wait till you have diabetes or another disease before they'll treat the obesity. That doesn't make sense. We should be more preventative. Because again, some of those once-a-week injections are $1,200, $1,400, $1,600 a month. And so it's access. For instance, some people might have great insurance. Say someone has state of Illinois insurance. and it covers all the meds. But then say someone has a private insurance or Medicare or public aid and it doesn't cover those things. Well, that's a lot of inequality, isn't it? Again, that's another show we can have.
Well, and thinking about, I mean, if you have to take it for 2 years.
Yes.
Once a week for 2 years.
Yes.
Oh my goodness.
And do I have patients that pay cash for it? Yes. But most of my patients obviously have private insurance, commercial insurance, and then most of the time it's maybe $25 a month. So it's very reasonable if you have insurance. But again, it's got to be insurance that covers weight loss meds.
Sure. So for diabetics, it's hopefully
covered.
More accessible. Okay.
Oh yeah. If it's diabetics, it's covered. But if it's just excess weight, maybe prediabetes, metabolic syndrome, excess weight with hypertension, hyperlipidemia, things like that, a lot of times insurance won't pay. But this is where then usually employers can make a difference. Like for instance, state of Illinois employees, they are represented well and their insurance says, yes, we will pay for anti-obesity medications. So certain employers will say, we realize obesity, excess weight does affect our employees, and so we recognize it as a disease and we will cover it.
Mm-hmm. Now, in administering this to people who are experiencing or trying to use it for obesity reasons, is it making it any harder for people with diabetes to get it?
Lacey, you hit unfortunately, there is huge supply issues.
Oh no.
So it is true that it's hard to get some of these medicines. Unfortunately, we've seen through social media, Hollywood, whoever, people sometimes use these medicines for vanity reasons. And they're not using it because they carry excess weight and it's affecting their health, or they have diabetes. And people are using it, oh, I want to lose an extra 5, 10, 20 pounds. And I get it, that's important, your self-image and your self-esteem. But because of the supply issues, some people with diabetes, it is hard to get, or certain dosages are hard to get, or certain medications or certain pharmacies are running out of it, and they do have to shop around.
Wow. Well, in our last couple of minutes here, is there anything about this topic that we haven't quite hit yet that you think is really important for people to know?
You know what? I think one of the things that, just to get across is, number one is that obesity is a chronic, complex condition, but it's treatable. The other thing I want to get out there to patients and to the community out there is that you are worthy of good health. And I mean that. Telling patients, you know what? I get it. I have patients that are in their 40s, 50s, 60s that wish they can go back in their 20s and make changes.
Yeah.
I have patients in their 80s who wish to go back in their 60s and make some changes. And so sometimes it's telling people, hey, when I'm meeting with them, this is your 10, 20 years ago. I promise you, if we don't make changes now, what do you think is going to happen 10 years down the road? And controlling your weight, realizing that you can treat that, and all the psychological stigma that comes with carrying excess weight. What that does to a person, it can really affect your mental health. So sometimes it's telling people, let's just even lose 5%. If you're overweight, let's lose 5% over your weight. If you're in the obese category, BMI greater than 30, let's get you to the overweight category. Just losing a little bit of weight, you will feel better.
And there's several folks that we've had on the show that they keep saying the long game. We're playing the long game. And I think because of maybe diet culture, the media, whatever it is, it's hard to focus on the bigger picture. It's more, I'm in this right now. And so kind of working past that. We do still have a couple of minutes. Is there anything else about this class of drugs or how they're utilized or connecting with a physician about how to go about getting them?
Yes, so I mean, when it comes to obesity, you know what, there's even a point where if medicines don't work, then there's bariatric surgery. And there's bariatric surgery along with medicines. So don't be afraid that if you need to lose 40, 50, 60, 100 pounds, there are doctors out there, there are providers out there that can help you. Look for people that, like me, that are obesity medicine certified. Look for people that have an expertise in this field of medicine and that you can get help. And if your primary care physician isn't versed in these things, then getting a referral to someone who has the expertise in this area, because we know that if we can even just help a patient lose 5% of their weight, if they're overweight and obese, the implications for their mental health, for their physical health, are huge. And we can, if you will, reverse some conditions or put some conditions in remission. So weight is an important thing. It's an important risk factor for many conditions, but there's hope and there's help out there.
And these are all just tools.
Correct.
I have unfortunately seen across social media, what have you, people trying to say that getting surgery is like an easy way out. And it's like, there's still so many steps that go along with that, and recovery and maintenance, like you said. So.
It's surgery, and all these things are tools. So the more tools, the more things we can implement to get someone healthy, especially when it comes to their weight, then the better off they'll be in the long run. The 3 rules I have for my patients for weight management, well, it's really 4 rules, but 3 rules.
You keep adding them.
Yeah. Number 1 is stop the weight gain, which sometimes is hard. Number 2 is lose weight, which is hard. Number 3, keep the weight off, which is the hardest of them all. Mm-hmm. And then number 4, rinse and repeat. Go back to step number 1. And so weight is a chronic, lifelong disease. And so sometimes it's, okay, stop the weight gain, and then lose a little bit at a time. And then over time, what can we do to make sure that weight doesn't come back on?
Mm-hmm. Well, you heard it here, folks. You've got your doctor's orders from Dr. Bernie Ranchero. Thank you for coming back on Being Well. I appreciate it.
I love being here. It's a privilege and an honor.
Good. We're so glad you enjoy your time too. And we hope our viewers enjoyed this episode of Being Well. And I hope you will join us next time.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.
When Sarah Bush Lincoln opened in 1977, it was with the promise to serve the community's healthcare needs. It has grown into a 2-hospital system with nearly 60 clinics that provide trusted, compassionate care.